So welcome everybody. Let's go ahead and get started. Today we have Marcos who's presenting for us. Marcos is a physician scientist from São Luís in Brazil, and he is going to be sharing a presentation that's coming up for a conference, the Kettle Brewing Society or KBS event happening in Europe later this year. So I'm sure he would welcome your feedback among friends before sharing it to the public. Not to say our friends at KBS aren't nice or anything, but let's get any kinks out now. So welcome, Marcos. You can take it away. Can you share?
Yeah.
Okay.
Yeah. Thank you, Ashley. Thank you, everybody. And good to see everyone. I will present the presentation of the KBS conference. I think the estimated time is 10 minutes, determined by the conference. I will try to do on this time. And so I hope receive some feedback from you. Can you see my screen?
Yeah.
Yep, thank you. So this is, let me see the Zoom. So I will present this paper. It's called Maternal and Alcohol Consumption and the Risk of Fetal Distress, Finds from the BRISA Birth Cohort. And I'm Marcos Campos. I'm master student in the program of public health in UFMA, Brazil. And I'm internal medicine specialist. And this is all the complete team from guys from Duke and UFMA as well. So why this issue is important? I changed my, oops. So why this is important? Alcohol use is a huge public health problem worldwide. And according to the literature, 1 in 10 women consume alcohol during pregnancy. And we know it impacts at higher stillbirth rates or worse perinatal outcome as low birth weight, prematurity, and birth defect. For example, the fetal alcohol syndrome. We know there is no safe alcohol consumption at any stage of pregnancy. And however, most of the evidence about the perinatal outcomes related to intrauterine alcohol exposure comes from high-income countries. In some places located in low and middle-income countries, for example, in Brazil, and especially at the city of São Luís, the prevalence of alcohol is higher than estimated by the WHO, for example. Here in São Luís, the prevalence estimated of alcohol consumption during pregnancy is more than 14%. And the aim of this study is to estimate the risk of adverse perinatal outcomes in alcohol users at different stages of pregnancy in a birth cohort in the city of São Luís, Brazil. This is a cross-sectional study aligned with data from a population-based cohort of birth. This cohort is called BRISA. This is an acronym of Brazilian Birth Cohort Studies, involved two big cities in Brazil, Ribeirão Preto, located in São Paulo, and São Luís, located at the state of Maranhão. This is a birth cohort that follow up children born in 2010 and 2011, and follow up across all the life course of the children. But we focus during the birth moment. We selected 4 maternities, hospitals, with the highest number of births in São Luís. And we selected 1 in each 3 births of prospective collected. We involved 5,212 children and mothers included on our final sample. We excluded the stillbirth or twin births. Every day, I trained the interviewers using a standard questionnaire and asked for the mothers and saw at the medical record some variables. For example, demographic and socioeconomic data, characteristics of pregnancy, or health problems during childbirth, some data about newborn anthropometry data, and about the consumption of the alcohol. They did some questions. For example, did you drink beer during pregnancy or wine or the distillated beverage? And the frequency in which trimester the consumption was made. We used the direct cycle graphic to select the potential confounders related of the exposure, alcohol use, and the main outcome, the adverse perinatal outcomes. Using the direct cycle graphic, we saw the potential confounder was selected as maternal schooling, family income, and prenatal care. It is related also with alcohol use and with adverse perinatal outcomes. So our exposure was the consumed alcohol during pregnancy, defined by each trimester and estimated per day and estimated per week. And the outcome was low birth weight, prematurity birth, fetal distress. This is for the babies. And for the mother, eclampsia or preeclampsia, maternal hemorrhage, gestational diabetes, and gestational hypertension. And the potential confounders was selected as family income, maternal education, and prenatal care. I have to say about the smoking during pregnancy was not selected as a confounder according to the direct cycle graph. However, we know the alcohol and the smoking sometimes happens together. And we use the smoking during pregnancy to perform some sensitivity analysis, and we do models considering the smoking during pregnancy as well. For the analysis, we use the Chi-square and Fisher-Zect test to perform a bivariated analysis. We use an adjusted and adjusted regression models using the Poisson regression with robust variance, using for the outcomes with higher prevalence, like low birth weight and preterm birth. And we use logistic regression for the outcomes, estimated the odds ratio. We use the Rosmer-Lemschol test to calibration of the model. We perform the analysis in R, and we follow the Strobe guideline to report the findings. So some results, we included more than 5,000 mother and infant pairs. The mother's age in median was 24 years old. Most of the sample was live-born sex male for the babies. And the prevalence of smoking during pregnancy was very low, comparing with the older cities in Brazil, was 4%. However, the prevalence of the alcohol consumption was higher, with 14%. The most consumed beverage was beer in all the trimesters. But we can see the most used happens on the first trimester, with higher, very higher when compared to all the second and the third trimester. Probably because some women don't know they are pregnancy, they don't know the status of the pregnancy during the first trimester, and is still the habitual consumption of alcohol. About the outcomes, the low birth weight and the preterm birth was the most frequent, and the preterm birth was 14%, and the low birth weight 9%. And the fetal distress was 1.5, 54%. And related with the outcomes of the mother, eclampsia or preeclampsia and gestational hypertension was the most common. Alcohol use, as I said, was 14%, and the smoking is very low. And for the adequate prenatal care, we saw in 37% of the sample. So the frequency related of alcohol, as I said, was most common at the first trimester, and the weekly standard drink, the median during all pregnancy was 1.25, and this was higher on the first trimester and was getting low during all the older trimester. And the weekly, this is the last table, was related to quarter of weekly standard drink among the alcohol use. And we can see the case of alcohol use was more than 3 standard alcohol, was 24, more than 24% of the sample. This represents, or in our sample, the most case of alcohol consumption was low to medium numbers of standard drink in pregnancy. However, we have some samples using a high dose per week. And related to logistic regression, comparing the outcomes with the exposure, the alcohol use, we can see no associate in an adjusted analysis for low birth weight and preterm birth. However, for fetal distress, we can see a high risk of fetal distress in women that used alcohol during pregnancy. We can see the more chance of her fetal distress when compare this outcome. And also for the unadjusted analysis and as well for the adjusted analysis. For the mother's outcomes, we can see the inverse. We can see a protective factor, for eclampsia and preeclampsia in women who use alcohol. This is counterintuitive, but we can see a protection factor here in that adjusted analysis for eclampsia and preeclampsia, and at the adjusted analysis. And we can see also at the gestational hypertension only on the adjusted analysis. So there is less chance to have that outcomes in women who use alcohol during pregnancy. This is analysis only for the first trimester. When compared the same outcomes, low birth weight, fetal distress, eclampsia, and gestational hypertension, is still with the same pattern. For the second trimester, we also see the same effect. However, here with the low birth weight in preterm birth during the unadjusted analysis, and fetal distress is a risk factor at the adjusted analysis. The third trimester is still with the same way, with associative fetal distress as a risk factor in eclampsia, preeclampsia, gestational hypertension with protective factor. This is another way to see, but here we are comparing the dose. And the blue lines represent the low dose with less than half the standard drink, and the another colors represent more doses of use. We can see the fetal distress is associated as well, independent as well with a low dose is still associated with fetal distress, but this not continue when we get more doses. But the low birth weight is a risk factor for the low dose. We have more chance of low birth weight. And for the gestational hypertension and preeclampsia hypertension, and preeclampsia, we have a protective factor with independently with the dose, except for the 1.1 and 0.1 to 0.5 dose of standard drink alcohol. For the conclusion, the alcohol used during pregnancy was reported by 14.5% of the women in São Luís, Brazil. The first trimester showed the highest levels of alcohol consumption, and beer was the most frequently consumed beverage across all trimesters. Even low to moderate alcohol exposure during pregnancy can increase the risk of fetal distress. We need urgent intervention during prenatal care to reinforce that no amount of alcohol is safe at any stage of pregnancy. So thank you very much. I hope it don't pass at the time.
Awesome. Thanks so much, Marcos. Like I said in the chat, feel free to put comments there, or you can speak. Did you look at the time? I think you were close to 10 minutes, but I think it's like 15. Could probably use some tightening up. Yeah. So that's really hard to do only 10 minutes. We'll welcome feedback, questions, comments from Marcos.
Yeah, Marcos, I would take the dosage analysis out of the presentation. And you can keep it on the slides if you want to talk about it, if somebody asks the question. I just think when you're looking at the dosages, because the groups shrink so much in size, you have such wide confidence intervals, it's very hard to make any assumption there. So I would be careful about that. I know in the graph, you put, you cut the graph on the 5, but I don't know what that value goes up to. So I'm assuming it's going to blow up, which probably means that there's issues in the feeding of the model there because of the size of the sample when you break it down into groups. But
is that graphic that you mean?
Yeah.
Okay. Yeah, it's very hard to explain this. Sorry, but this is related with.
I think you can just in the presentation say, we looked at dosage effects. There's a difference in the sample size changes across groups in dosage, but we did notice that any level of exposure increased. That should be enough for you to say. And then if somebody wants more information, you can share. And then the other piece I'm going to say, and let other folks ask the questions that I'm probably thinking as well, is that avoid using the word effect and go for the word of association. This is an exploratory analysis. And the effect, even though you have a causal pathway, there's a time component, you still have so much confounding that is not addressed for, or that we have to look in different ways to get that precise measurement there, that I would be more comfortable just saying, this is how I found this data to be associated, and not saying they are causing each other. Okay?
Okay, I got it.
Right.
And this is for the unadjusted analysis, and I have another one with adjusted analysis. So this is, I think it's not practical to explain this, and don't give any new information here.
Yeah.
Do you usually include the discussion section during the presentation for the KBS? This is not clear on the rules.
Just the conclusion. The conclusion is good. Yeah.
Okay.
Other comments or questions? One thing that I didn't see acknowledged, and again, this all comes with the caveat that you have only 10 minutes, so you won't be able to be exhaustive. But something that I didn't see, which I would maybe expect in an introduction or conclusion, you did make a short reference to it, talking about the first trimester being that many people don't know they're pregnant. But the fact is, we know that most pregnancies are unplanned. So I would say, for example, in the conclusion, when you say urgent need for prenatal interventions, I would even say we have an urgent need for preconception education and intervention, because people aren't, if prenatal intervention's happening, that's great for those who are in prenatal care. But we have an issue with people probably who are not in prenatal care, I suspect. So I would want to see something about the fact that pregnancies aren't planned off in many cases. Because that's going to have an implication on the solution that you're talking about in the conclusion.
Yeah, also, Ashley, I agree 100%. And we have in Brazil, in SUS, the family planning, when you have a preconception. But we know most of the cases don't go to the family planning. But this is so this is a good suggestion. And this is actually is a limitation of this study, because the mother was asked only during the birth moment, and so that they could remember as well during the first trimester. This is a limitation of this study. But
yeah, that's an important point.
Yeah, the recordatory could be compromised.
So, what is your take on these eclampsia result?
It's interesting, and I found it challenging to really understand what that means. So can you go back to the data for the third trimester?
Yeah.
Didn't we find something similar in a Tanzanian data set? What was the outcome that we were looking at that we found a similar kind of counterintuitive result for these perinatal outcomes, do you recall? I wish we had Charlotte or Elizabeth.
Part of what I was thinking as I was looking at this was alcohol has been known to increase your blood pressure. That study is done mostly in men, not in women. But alcohol is also dehydrating, and so that will lower your blood pressure. So depending on the amount that you're drinking, you could have it go up and down. By the time you're talking about eclampsia, that is going to be an increase in fluid in your system. And so that dehydration component from alcohol use might actually be slightly protective. But that's going to depend again on how much you're intaking and your protein amount in your body and like your overall nutritional status for the risk of eclampsia and preeclampsia. Now, I'm also slightly concerned because I think that the people who have eclampsia and preeclampsia are most likely the people who aren't getting prenatal care. And so I think that there's so much compounding between all of the different variables that I'm not sure that this is not something else.
We tried to look into that. That's why we did the analysis on those that the drinking data from first trimester, the drinking data the second, we kind of compounded them. So anybody that drink on the second trimester also drink in the first.
Yeah.
So we kind of we were compounding that to try to adjust for this. I just feel like in this paper we're gonna have to discuss this very clearly, both in the sense of saying there might be something here, and then Marcus has found some literature that talks a little bit about why alcohol could be in this. But I think I would put all my tips on the fact that there's probably so much confounding that we are not adjusting in these results that could be explaining this.
Because if you get to the point of eclampsia, then we have failed our prenatal care, right? Because we should be able to identify hypertension early enough to not allow you to get to eclampsia. Preeclampsia, fine, but never to get to eclampsia. So
yeah, but when we broke down the time we found them drinking, either first, second, third, the association is consistent. So even if for those that we got
first trimester, not the third trimester, you still have a protective effect from it.
And if you continue drinking, so that for me is what points me to this hypothesis that there's something in bias of responding there. Marcus, can you briefly talk a bit about missing data on the 3 times of data collection and in the outcome, and then how you addressed for those?
We had a few missing data for the oldest sample. We have all the informations actually, but curiosity, I could split eclampsia with preeclampsia because on the data set is the same variable. I don't know why, but I only have this information. But curiosity, this is not a new in literature. Other studies suggested a protective factor for eclampsia and preeclampsia, and other studies represented a neutral risk or high risk, for example. And this is very similar with smoking during pregnancy. This is protective factor for eclampsia and preeclampsia. But for the smoking, there is an explanation. The nicotine can cause relaxing of the placental vessels and is a low risk of eclampsia, for example. There is a biological explanation. For alcohol, this is not confirmed. And on the paper of this analysis, I explore more details about this, but there is an interesting paper that suggested the following. The most used beverage for who had eclampsia or preeclampsia was wine. And for who use wine is people with more income, with more rich one, for example. And they use a sensitive analysis for the kind of beverage. And using this adjust, the eclampsia and preeclampsia lose the association. I tried to do the same using adjustment for the kind of the beverage, but it's still the same. Don't change the result. But there is a possibility of another confounder here, and we can see about this confounder. And so there is no one explanation literature that justifies it. But even if a lot of hypotheses.
Right, that's really interesting, because even if the type of beverage you treat like a confounder, there's another it's not probably the root of the confounding, as it were. That's related to some questions that came up in the chat. Rafael was asking, do people who drink during pregnancy, are they usually younger than others? I see Natan asked, are there differences in mother's age or ethnicity for those with or without eclampsia, which goes to the adjusted analysis. Did you list here what the adjustments were?
It's in the methods.
In the methods, can we look at that really quick just to answer some of those questions?
I didn't perform the analysis with the with the age mothers, and
you did or you did not?
I did not. But the most women was younger, and even in the exposure group or at the outcomes group, there is no difference. But I didn't consider here on my confounders the age, mother's age. For example, we know more than 35 years old increase the risk of eclampsia, and less and adolescent pregnancy as well increase the risk of eclampsia. Maybe I can do some analysis about this.
I think age is a huge factor that we can't ignore. I would also say that that is going to impact your choice of alcohol use, your amount of alcohol use. It's going to be it's going to be very much associated with your schooling, your family income, pretty much everything else that's up there, right? So I don't think we can ignore age. I think we have to add that one in. And I think that might change our data a little bit, honestly. I am actually also surprised about the gestational diabetes. I would have anticipated that an increased alcohol consumption would have some association with gestation, or at least a signal that it might be associated with gestational diabetes, and there was nothing there, which is quite interesting.
I'm wondering if there's some nutritional factor that has to do with that and the hypertension.
Oh, I'm sure.
Well,
I'm sure.
that it's hiding some kind of access to nutrition, which is a protective factor, right? If you're accessing alcohol, you might be accessing other nutrition, right? Wow. Natan has something to add, please?
Yes, so I just want to ask about the decisional risk, because in Brazil we separate among three groups. So the high risk, the intermediate risk, and the common risk. I'm not sure how to translate that. And it includes some social demographic factors and some physiological factors. So I was thinking about, was it used in the analysis, or is it planning to use in the analysis, or anything like that?
So I can be wrong, but I don't know if there is a problem because we use a probabilistic selection of our sample independently of the risk. We don't select it based on uh, high risk of pregnancy or something else. We selected everyone, not everyone, but one in each three births, independently of the risk. And we
Yeah.
use 4 different maternities. Of course, 2 of maternities was a high risk maternity, and 2 was a common risk, a low risk pregnancy. And I think is mixed. I don't
Yeah.
know if on my data set I have that information of the right risk or not the right
Yeah.
risk, but I did- how can I say? I just consider the outcomes, that outcome, uh, gestational diabetes and gestational hypertension, only the new cases. For example, a woman could has hypertension previously the pregnancy. I didn't consider this case as outcome. I consider a new case of gestational hypertension or gestational diabetes. That makes sense.
Yeah,
Was I clear? Yeah.
but
And
my
so
question is
the
more
previous
related.
risk I didn't consider.
Yeah, because what I was thinking is that since we separate those mothers, let's call it that,
Mhm.
into three groups, and each group has a risk of both low birth weight or premature birth or gestational diabetes or gestational hypertension, depending on the risk for the pregnancy. I was curious if it was something that it was used, because like non-white mothers would be directly into the intermediate, it wouldn't be common risk.
Mhm.
So even if it's in the common risk maternity, it's not a common risk pregnancy. So that's what I was thinking about, because there's a lot of those factors that could influence the outcome, but probably something that should be looked out, because there's a lot of confounding on those things. So just
Yeah.
a
Yeah.
thought here on the side.
Thanks, Natan. I want to squeeze in one more comment and then we will close out. Eduardo?
Okay, thanks. Marcus, great job. I was thinking about Natan's question when he mentioned risk pregnancy. We usually in Brazil divide these patients from primary care to hospital care sometimes, so it's prenatal care has a percentages of. You have access to these data if you're maybe you could check how many of those women were on prenatal care hospital setting, or maybe some more specialized ambulatory setting than primary care, and that would be a proxy for their risk of pregnancy, maybe. Not sure if you have those.
Yeah, the selection of the mothers was made at the maternity. I didn't comment, but in 2010, in São Luís, we had only one private maternity that was included on the study. So we included the public one who uses SUS and the private one who use private insurance, for example. And we included everyone, independently of the setting or independently of the prenatal care. We go to the maternity because the women was there. Of course, the who had babies not in maternity was not included, but this is very hard. But we included everyone independently of the where the women use the prenatal or not. I'm not sure if I respond to you.
Actually, now you just added up another layer of confusion because if you're including private and public maternity, then this is something very mixed up because in terms of social vulnerability, if we include people who have access to private hospitals and private insurance, especially talking about northern Brazil, which is Maranhão, so the northern places, there's probably great disparity with those pregnant women because those who are able to pay for private insurance probably have different consultations and access to different kinds of food and exercise. And so this is something interesting to have a look at because this is very heterogeneous in terms of social vulnerability. And this has everything to do with hypertension and diabetes, and consequently with preeclampsia and eclampsia.
All right. We'll leave it there. I think if you have other comments or questions for Marcos, you can find him on our Teams group. So thanks, join me in thanking Marcos for presenting with us today, and thank you all for the